Bismillah ar-Rahman ar-Rahim. This is Dr. Khalid Diab. Welcome again. This is the second part of my presentation titled Basic Clinical Management for Abnormal Uterine Action, Uterine Dystocia, and Labor Progress Abnormality. In the first part, we discussed an overview on the topic, normal uterine action and labor progress and types of abnormal uterine actions. In the second part, abnormal labor progress will be discussed with its four main clinical types. Labor progress abnormalities may be either failure to progress or precipitate labor. Failure to progress is a clinical term. With deviation from the norms, labor is characterized by slow progression, protraction, and eventually labor arrest. It is usually overdiagnosed as cephalopelvic disproportion or fetopelvic disproportion, which may be true, meaning discrepancy between the fetal and pelvic sizes, as in macrosomia or contracted pelvis, or relative, as shown by malpresentation and malposition, or multiple pregnancies. Obstructed labor, if neglected, it will eventually result to an increase in maternal or fetal morbidity and mortality. The third P is power, which is mainly uterine contractility, whereby its abnormality is diagnosed usually by exclusion of passages and passenger abnormality, and is defined as the more common primary dysfunctional labor or uterine dystocia or secondary dysfunctional labor related to abdominal muscles effort pushing in the second stage. It should be noted that failure to progress or dysfunctional labor represents almost 50% of emergency cesarean section at any hospital and may be a combination of mechanical and dysfunctional factors. As regards the risk factor associated with fetopelvic disproportion, the following table shows the duration of each stage of labor and the maximum allowed duration for each stage according to Friedman. Although new labor curves have been developed, which changes the original duration and limitation as labor has been slower at certain stages, yet for the undergraduate, the classic data of Friedman and WHO partogram, original and modified limits are to be used. The concept of active management of labor was first implemented by O'Driscoll and colleagues at the National Maternity Hospital in Dublin in 1968. This management system contains both organizational and medical components, with the physician supervising normal spontaneous labor on nulliparous women and intervening only when labor progress slows. Active management of labor is a system designed to ensure labor progression and intervene to decrease dystocia, particularly in the first stage. The benefit of shorter labor and reduced maternal and neonatal infection rates without a concomitant increase in other maternal and neonatal morbidity are proven benefits. A consistent decrease in the cesarean delivery rate has not been statistically demonstrated with active management of labor. Despite the use of early amniotomy, high-dose oxytocin regimen, and frequent cervical examination, patients seem to be satisfied with a shorter labor. Discussion of active management of labor components and its philosophy will be done in the face-to-face session. Labor progress abnormalities has been classified recently into only 4 main simplified abnormalities with clear clinical management: a prolonged latent phase, 2 active phase abnormalities including a protracted and an arrest disorder, and a prolonged second stage abnormality. Discussion of each of these abnormalities and their management will follow. The latent phase is characterized by regular uterine contractions that soften, efface, and begin to dilate the cervix. The end of latent phase occurs when the active phase begins. This is usually by 4 cm dilatation with Friedman curve or in the WHO original and modified partogram. A prolonged latent phase can be defined as equal or more 20 hours for the nullipara and equal or more 14 hours for the multiparous women. It tends to be longer in induced labors than spontaneous labor, but the active phase and the second phase have similar duration whether labor is spontaneous or induced. Risk factors for prolonged latent phase is shown in the following slide. Management options for spontaneously laboring women who are not tolerating latent phase include therapeutic rest or uterotonic drugs. Caesarean delivery should not be a primary treatment for laboring women not tolerating latent phase. For women who are tired and uncomfortable in early latent phase, we suggest therapeutic rest rather than oxytocin. Morphine 5 to 10 mg intramuscularly and intravenously simultaneously, not to exceed 20 mg, gives temporary relief by providing analgesia and sedation. Approximately 85% of women treated with this regimen will awake up in the active phase of labor. Oxytocin is appropriate for women who is well rested or has already received therapeutic rest or have another indication to expedite labor. Details will be discussed in the labor induction, labor augmentation presentation later on. Artificial rupture of membrane alone should be avoided as it is associated with increased cesarean section rates. The diagnosis of a protracted active phase is made in women, whether nulliparous or multiparous, at or more 4 cm dilatation with the WHO partogram, who are dilating less than about 1 to 2 cm per hour, which reflects the 95 centiles of cervical dilatation. For these women, we ensure maternal and fetal well-being and a well-hydrated, sedated, and empty bladder mother, and we administer oxytocin and proceed with amniotomy if there has been adequate fetal descent. If the head is high, we delay amniotomy, administer oxytocin for 4 to 6 hours to allow fetal descent. A controlled amniotomy is performed if the head is still high and not well applied to the cervix. We use a high-dose oxytocin regimen regardless of parity, except in women who have had a previous cesarean delivery. The diagnosis of active phase arrest, on the other hand, is made in women at or more 6 cm cervical dilatation with rupture of membranes and either no cervical changes for 4 hours despite adequate contractions, or no cervical changes for more than 6 hours with inadequate contractions. In these cases, we proceed with cesarean delivery. If labor is progressing either slowly or normally, we continue oxytocin at the dose required to maintain an adequate uterine contraction pattern. A pragmatic approach is to diagnose a prolonged second stage of labor when a nulliparous woman without epidural anesthesia has pushed for 2 hours or 1 hour for a multipara. according to WHO partogram. An additional hour is added for women with epidural anesthesia and sometimes for occipitoposterior to allow for the long internal rotation, yet with increased risk of operative delivery. We only allow labor to continue if our judgment suggests that safe vaginal delivery is achievable. Yet, with recent labor curves, a longer duration for both nullipara and multipara may be given. Compared to latent phase, a prolonged second stage has potential clinical challenges and adverse consequences. Prolonged second stage in multipara women should be carefully evaluated by a senior obstetrician and should be dealt with case by case, as maternal, fetal, and neonatal morbidity and mortality is high. And for women in the second stage with a minimal less than 1 centimeter or absent descent for 60 to 90 minutes of pushing and uterine contraction less frequent than every 3 minutes, we begin oxytocin augmentation. Of note, in the second stage, we are more concerned, especially in multipara, about the possible physical or mechanical issue, malposition, malpresentation, or macrosomia, slowing descent rather than hypocontractile activity. We avoid operative delivery, vacuum forceps, and cesarean in the second stage as long as the fetus continues to descend and or rotate to a more favorable position for vaginal delivery, as long as the fetal heart rate pattern is reassuring. Prompt operative intervention is indicated for fetuses with category 3 fetal heart rate tracing regardless of labor progress. Obstructed labor is a form of over-efficient uterine action often seen in multiparous uterus. Discussion will follow. According to Philpott in 1982, obstructed labor may be defined as failure of descent of the fetus in the birth canal for mechanical reasons in spite of good uterine contractions. Obstruction often occurs at the pelvic brim, but may occur in the pelvic cavity or in the pelvic outlet. It occurs among 1 to 3% of all labors. The following table shows possible maternal and fetal etiology for obstruction. Also, the following table shows the possible maternal and fetal risks associated with neglected obstructed labor. As for clinical presentation of a woman with obstructed labor, in most cases, prolonged labor precedes obstruction. However, in the grand multiparous women, labor may be quick and relatively silent, and in the presence of a malpresentation such as transverse lie, obstructed labor may rapidly occur. Signs and symptoms of maternal exhaustion and stress include dehydration, oliguria, ketosis, signs and symptoms of sepsis, and the fetus may show signs of distress and mostly is dead. When the fetus has been dead for several days, significant gas may be produced from the purification and the uterus become distended and tympanic. The terminal signs of severe intrapartum infections are septic shock, circulatory collapse, hypotension, and rapid thready pulse with a subnormal temperature. Abdominal examination reveals the state of the uterus, tonically contracted, with the formation of what is called as a pathological or a retraction or a bandle ring between the upper and the lower uterine segment. Possible rupture uterus may occur with vaginal bleeding, and the state of the bladder usually distended, dilated with the hematuria. Vaginal examination. Vaginal findings usually reveal the cause of obstruction, cervical changes may be you feel a dilated cervix, usually dilated cervix, and a ballooned dry vagina. Obstructed labor should be an obsolete term in modern obstetrics. In the face-to-face session, we will discuss possible preventive measures. Prophylactic treatment include the standard procedure for obstructed labor is cesarean section when the diagnosis has been made. The choice of operative procedure is dependent on a number of factors, including the woman's condition, intact or ruptured uterus, type of rupture, facilities available, and the experience of the surgeon and the fetal condition, whether living or dead. Surgical option will be discussed in the face-to-face session and will include total or subtotal hysterectomy, laceration repair and tubal ligation, laceration repair alone. Historically, destructive operations such as craniotomy, decapitation, evisceration, and clitotomy may be used in jungle obstetrics. The key message in obstructed labor: proper management of normal labor is essential to prevent obstructed labor. Continuous and thorough assessment of the woman and her fetus contribute to limit negative outcome by providing opportunity for timely and appropriate treatment. If obstructed labor is identified, prompt treatment is required to save the life of the woman. It is not always possible to save the life of the fetus. Constriction ring is defined as a persistent localized annular spasm of the circular uterine muscles. It occurs at any part of the uterus, but usually between the junction of the upper and the lower uterine segment. It occurs at the first or second or even the third stage of labor. The etiology is unknown. Predisposing factors including malpresentation and malposition, pre-labor rupture of membranes, intrauterine manipulation under light anesthesia, premature attempt of instrumental delivery, and improper use of oxytocin as intramuscular or its use in hypertonic inertia. Cervical dystocia, on the other hand, is defined as failure of the cervix to dilate within a reasonable time in spite of good regular uterine contraction. It may be organic, secondary to previous cervical operation or trauma, or functional, primary due to overactive sympathetic stimulation or due to cervical fibrosis. Clinical diagnosis and complication and management of both conditions will be discussed in the face-to-face session. Precipitate labor, also known as rapid labor, is defined as expulsion of the fetus within less than 5 hours of the commencement of regular contractions and is typically less than 3 hours. There are several factors that can impact a rapid delivery and is shown in the following table. Rapid labor have a number of other potential difficulties for the mother or the baby. The most obvious difficulty with rapid labor is emotional turmoil. Many women feel disappointed as they look forward of the birthing process and are surprised by a rapid labor. A few practical concerns of rapid labor is also the location of birth. Other risks, maternal and neonatal, is shown in the following table. How can you manage or cope during rapid labor? Though you cannot control the speed at which labor progress, there are several steps that you can follow in order to take control of the situation in the event of rapid labor. These include: call for immediate help or ask someone to get help. Stay in control by using breathing exercise and calming thoughts. Have a partner with you all the time. Remain in a clean, sterile place until help arrives. Lay down either on your back or on your side, and most important is to avoid recurrence. Previous precipitate labor may be an indication for induction of labor in the next delivery. This is my summary slide shown in two tables. Do not forget in clinical management to exclude disproportion, malposition, and malpresentation, exclude maternal and fetal distress, ensure adequate hydration and sedation. For this clinical case, the student is advised to prepare for discussion in the face-to-face session. A 25-year-old female, para 1001, with a living healthy female, 2 years old, after a spontaneous uneventful vaginal delivery. She is pregnant 38 weeks, seen at the ER, with lower abdominal pains of 6 hours duration. She has irrelevant past and family history, no history of vaginal discharge or vaginal bleeding. Her fetal kick chart is satisfactory. Her vital signs were normal. Abdominal examination revealed single intrauterine pregnancy, cephalic back to the right, non-engaged floating head, 4/5 above the symphysis pubis. She is contracting 1/10, mild to moderate, lasting 10 seconds. Fetal heart rate are regular and 140 per minute. Her pelvic examination revealed a cervix soft, posterior, 3 cm dilated, 2 cm length, membranes are intact, head is not well applied on the cervix, and the pelvic capacity is adequate. First question, what's your primary clinical management and what's the rationale? Second question, is there an alternative management and what is the rationale? Hope the presentation was clear and helpful. The student is advised to read the recommended text and see YouTube links, and to be prepared with questions and discussion in the next face-to-face session. Thank you for your time.